introduce you to our speaker, Dr. Clint McKinney. Dr. Clint McKinney is an emergency department physician in rural Minnesota and has worked in healthcare for over 30 years. He has 14 years experience as a rural family medicine physician, which includes both private practice and large healthcare systems. Dr. McKinney is a clinical associate professor in the Department of Health Management and Policy at the College of Public Health at the University of Iowa. He is also Deputy Director of the Rural Policy Research Institute Center for Rural Health Policy and Analysis. Dr. McKinney has served on various national committees for the Institute of Medicine, the Department of Health and Human Services, the American Academy of Family Physicians, and the American Medical Association. He is the former medical director for a globally capitated primary care group and is a nationally recognized rural health advocate, consultant, speaker, and author. Now, I'll turn it over to Clint.
Thanks, Kim. And we'll get started here in just a moment. There we go. Well, this is, as Kim said, this is kind of a part 2, and it's also 2 parts as well. So if you will kind of bear with me, what we're going to do is start off talking a bit about strategic action planning, and that's based on the conversation we had a couple weeks ago surrounding the value-based care tool. And I'll talk about that in just a little bit. Then we'll jump to a bit of financial planning. And this is dangerous. Never trust a physician with numbers. But anyway, I'm going to do my best to talk about a pretty exciting tool that we've developed to evaluate your future as critical access hospitals. So let me start first with the strategic action planning. And as an intro to that, this is the organization that I'm working with and that Kim is working with to produce these webinars. And this is the Rural Health Value Project that I help lead along with my colleagues at Stratus Health and at the University of Iowa. You can see our vision there is to build a knowledge base through research, practice, and collaboration. It helps create high-performance rural health systems. And we hope to do that by providing tools, resources, and assistance to people like you, people who are rural health providers and rural health communities that are interested in making the successful transition from a volume-based world to a value-based world. So I encourage you to take a peek at our website for more resources. One of the resources that we have there, we talked about 2 weeks ago, is the Value-Based Care Strategic Planning Tool. And again, to let me review with you, the tool's purpose is to assist rural healthcare organizations develop value-based care capacity. So we want critical access hospitals and clinics to actually be moving in a way that allows them to deliver value-based care, so quite frankly, they can access value-based payment. You can't get paid for value-based care unless you're actually providing it. We've also found that those of you who don't attend these kind of webinars sometimes need a little bit of help understanding the way the world is moving. So we'd like to use this tool to educate leaders and directors and stakeholders. And what we'll talk about today in more detail is once we've completed this value-based care strategic planning tool, how do we take that information and prioritize it as part of our strategic planning? And then lastly, it's a little bit of a self-serving purpose, and that's for us, is we want to be able to identify the tools that you need, the resources that you need to move from this volume-based world into a value-based world. Here's the way the tool is designed. It's an online assessment tool designed to assess 121 value-based care capacities grouped in 8 categories. And very quickly, those 8 categories are governance and leadership, care management, clinical care, community health, patient and family engagement, performance improvement, health information technology, and financial risk management. And if you think of strategically your organizations and how they're going to be successfully moving into the future, I think you'd probably agree that these 8 categories are all essential parts of your strategy. So that's why we designed it that way. And you'll even see on our website, ruralhealthvalue.org, that we set up our tools and resources to follow this rubric. Now, capacities. I mentioned capacities, and we're measuring 121 different capacities. It's generally, the tool is generally designed around a critical access hospital, generally. but it could be used for differing organizations. It could be used for an FQHC, or it could be used for a tweener rural hospital, for example. A little bit more difficult for a system, but yet we could probably be used there some as well too. But if you think about it, when you look at this tool, think of it, it's kind of designed around a critical access hospital. Here's some examples of capacity so people kind of know what I mean by a capacity. So one capacity is the healthcare organization, that's HCO we've abbreviated, assesses and identifies patients at high risk for poor outcomes or high resource utilization, and then assigns care managers to them. That's the capacity you would have in your organization to deliver value. Next, for non-urgent clinic visits, pre-visit planning occurs for complex patients. We want to be able to provide not just what the patient is there for, but what the patient needs when he or she accesses us at our hospital or clinic. And we need to plan for that. That's value. That's value. My third example here is the healthcare organization strategic planning incorporates measurable population health goals that reflect health needs of the community. If you think back to the triple aim or the three-part aim of CMS speaks about, you will remember it speaks to better care, improved community health, and smarter resource utilization, smarter spending. So we need to be paying attention to what's happening in our communities, obviously. Now, when you go through this online tool and you assess those 121 different value-based care capacities, you'll do so in this way. You'll rank them or rate them. Is this particular capacity in your organization fully developed and deployed? Will everybody in your organization know that this is what you're about and what you're doing? Or is it developed, it's ready to go, in fact, it's partly deployed, but incompletely so? Or thirdly, is it in development? You think this is a good idea, you devoted some resources to it, but yet we haven't really fully fleshed out this capacity, this value-based care capacity, nor have we deployed it through the organization yet. Fourth, you've talked about it, it's in discussion, but really hasn't gone anywhere yet. Or fifthly, that just doesn't apply to us. Now, I'd caution you on that one. I think of all those 121 will apply to you or your community in some fashion at some time. Now, they may not apply now, but I bet they will in the future. I bet they will. And then the last one, I haven't even thought about that. Not even considered that particular assessment. So that's what we ask people to do, is assess it that exact way. So now we think about this. We've just spent about an hour and a half with our leadership teams, and we've assessed all of those 121 capacities in our particular organization. If you've done it online and you submitted it to us at the University of Iowa, you will get back pretty quickly. We promised within 2 weeks, but actually we just had a group of about a half a dozen, and I think we had the report out to them in about 2 days. But we'll send you a report. We'll send you a report that lists your strengths, your opportunities, and your considerations. So your strengths are those capacities that you assessed as 1 and 2, fully developed and fully deployed, or fully developed but incompletely deployed. Those are your strengths in your organization currently. Then there's the opportunities. That's listed as number 3. It's in development. You devoted some time and thought and resources to it, but just hasn't been fully developed, fully fleshed out yet, and it hasn't been deployed. And then there's considerations. Those are the 4, 5s, and 6s. You know, it's in discussion, it's not applicable, haven't really considered it, or heaven forbid, you actually left one of the darn things blank. So that would be the considerations. And what we do with these is we do kind of like a SWOT analysis with this. But I think it's actually even more fun because this is going to be really action-oriented and action-focused. So we're going to really kind of be concentrating on what our capacities are that are in development. Now, the reason why I really key in on this as the number 3s, you're already doing the 1s and 2s. Good for you. Good for you. We want to kind of make sure that you keep up, as I say, you want to keep the foot on the throttle for those. And you want to measure your success and celebrate your success. And then the 4, 5s, and 6s, well, in your particular organization, you've made a decision that is of less priority, but number 3s, in development. You've already decided that this is important. You've already devoted some resources to it, and it won't take that much more to take it over the finish line. So that's where we believe That's where opportunities really lie. So what we'd ask you to do then is take a look at your number 3s and then start thinking about them with what I would call support criteria. So let's take a capacity number 3 and ask ourselves, how much leadership commitment is there to developing this particular capacity to fully develop and fully deploy? What organizational resources are available or are going to be necessary to actually take this particular capacity from in discussion up to fully developed and fully deployed? And then lastly, what's our interest? Is this something we're excited about, we think is valuable? What's our staff interest? And then once we look at this capacity, we want to rate it with each one of those commitments, resources, or staff interests with kind of a rating scale. 3, strongest support, 2, mid-range support, and 1, the weakest report. And I'm going to show you how this all rolls up in just a second. So what we do is we add these numbers for each capacity, and then I'm going to suggest one other kind of thing to add here. I call it the Gestalt factor. So maybe we find, I'm going to go back for just a second on our slides here. Maybe we find a particular capacity that has strong leadership commitment, but the organization resources a little bit tight and staff don't quite know what this is yet. But we as a group kind of say this is the Gestalt factor. It's important even though it's not rising to the top of our numerical ranking system. And then what we'll do, we do our ranking system and we'll pick 2 or 3 of the highest support categories for action plan development. Not 15, not 30, not 10, and in fact, maybe we could do that. And you'll burn everybody out, and everybody will be rolling their eyes and wondering how on earth we're going to do this. But if we concentrate on 2 or 3, for example, and then we do those, and then we move forward to the next 2 or 3. This is kind of in the same vein as Plan, Do, Study, Act. You all who have a quality improvement background have probably heard that most quality improvement projects really shouldn't last more than about 3 to 6 months, if that. So the idea is that we focus our attention, and that way we'll get things done. So let me show you how this kind of rolls up. You can develop a prioritization table. So I used just some examples here. Let's look at the top one. Generate action lists for providers of patients who are due or overdue for services. This is in essence a tickler file for preventive services or chronic disease management. So we think leadership is committed at a rating of 2 here. Remember, 2 is, we'll go back real quick again. So 2 is mid-range support. 3 is the strongest support, and 1's the weakest support. And our resources, yeah, we don't really have the resources very well to do this. This is going to take more resources than we think, but we're strongly interested in it. So we add that up to a 6. You can see we've done that for 1, 2, 3, 4, 5, 6, 7 different capacities here. And let's just assume that these were all number 3s when you completed your value-based care tool. And then we circle the top 2. But oops, you know, there's one that fell off the bottom there, and I highlighted it. This one, the leadership says, you know, I rose from the ranks from quality improvement. I know the importance of quality improvement techniques and performance improvement strategies to this organization. I feel it's very important that we train managers in continuous quality improvement techniques, and by God, we're going to do that. So it ranked low, but our Gestalt says that this is important. This needs to rise to the top because I think we could argue that continuous quality improvement techniques are what's going to drive much of performance improvement towards value-based care. So we actually circle 3, our 2 highest scores and the one that we give a Gestalt ranking to for development action plan. That's our prioritization process. How we take 121 different value-based capacities, identify those that are most ripe for full development and full deployment. Those is what I call the in development number 3s. And then prioritize those based on leadership commitment, organizational resource requirements, and staff interest. And then we just do a numeric pick of those along with our Gestalt factor of, in this particular case, continuous quality improvement techniques. Next thing we need to do is, okay, so we've got our ideas, we prioritized our issues, our goals for work, and now what we need to do is we need to develop action plans for each one. Now, the action plans may differ some, but I think there are some mandatory action plan inclusions. Number one, we need to have measurable objectives. And there'll be multiple, generally there'll be multiple objectives within kind of one action plan, but they need to be measurable. Even though almost all of these actions will be developed by teams, we still need a single person accountability. We need the one person who says, this is my job, this is my action plan, I'm responsible, I'll be reporting to the group, I'll keep everybody on track. So single person accountability. You know, how many times have all of you heard or even said, everybody in a rural healthcare organization wears many hats? Yeah, we've all heard it about 50 or 80 times, and it's true, we do. So we need to understand when we ask our staff to do additional action planning, one, it's not above and beyond the call of duty. This is our job to do this, especially around management and leadership. But it does take time. It takes time, and that's resources. So we need to make sure that as we set up our action plans, we have the resources, whether that be time or education or maybe even dollars, to be able to be successful. And then lastly, we need the timeline and due dates. So we need to stay on task, on track with timelines and due dates. This requires leadership attention. These are not the kind of things that I think a leader can set in motion and then walk off to the next burning platform. This needs leadership attention, and I think, as I've said before, this attention is the currency of leadership. When leaders want to get something done, they attend to it, and we achieve what we attend to. I don't think that's very good sentence structure, but nonetheless, you get the gist. That is if we are attending, if we're paying attention, if we're checking in, if we're offering support, that is the way our projects will get done. Now, only as a sample, I don't expect you to read this whatsoever. This is just simply an example, and admittedly an abbreviated one, of an action plan around offering chronic disease management services with a kind of theoretical start date and some theoretical due dates. You can kind of see what I mean here is we need to kind of break down our particular plans to individual tasks or objectives and then assign that accountability, the resources that are required, and a due date. And again, your action plans may look different. That's okay. But nonetheless, you'll get what I understand by developing an action plan and then sticking to it. In fact, the results of those action plans roll up into your balanced scorecard that demonstrates performance at an organizational level. Very, very important. So I wrote what's next. So we use this prioritization process to select 2 or 3 value-based care capacities for action. And we described how to do that. We can rank them exactly by leadership commitment, organizational resources, and staff interest. Once those are selected, we develop our action plans. And the leaders must stay engaged to go out there and do the work that we all really moves us towards a value-based care that allows us to actually access that value-based payment that is coming. So let me stop there, and Kim, I'm going to stop for just some questions on this before moving on to the next part of the presentation. So if you could open up, or questions would be great.
Absolutely. Absolutely, that sounds great. Please feel free to type your question into the chat box to the left of the screen, or you may press *2 to unmute your line to ask Clint any questions you may have about the first part of his presentation. It looks like Debbie has a question, not about the first part.
No problem.
Anyone else have any questions? Well, Clint, I'd say go ahead and move forward. Feel free to type any questions into the chat box as as Clint presents the second half here, and we'll stop for questions at the end.
Sure. So we can do that. So So yes, type in your questions regarding strategic planning and action planning and prioritization if you wish, and we'll try to get to those at the end then. So the next part of this is definitely different. So as I kind of said, it's dangerous to be, allowing the physician to kind of talk about fee-for-service and cost-based reimbursement. But I think I know enough to be dangerous with this. And I am excited, though, despite that disclaimer, I'm very excited about a tool that we at the Rural Health Value Team, along with Eric Schell, have developed that I want to talk about now. But by way of background, let me talk about some things that we've talked about in the past, just to kind of remind you. Accountable care. So a definition for accountable care is monetizing the value derived from increasing quality and reducing costs. So let's contrast that to something. How would you define fee-for-service? Well, I think I could. Monetize the value derived from increasing volume and increasing prices. So that's how we do make money in fee-for-service. We make money on monetizing volume and prices. So ask yourself kind of in your mind, is that the way you want your doctor and hospital to act for your own family? And I would argue that most of us in a time of reflection would say, no, we don't. Instead, we want our providers to be rewarded. That's the monetizing the value. Rewarded for increasing quality and reducing costs. Now, invariably, there is some guy, almost always male, almost always with gray hair, and I kind of realize, wait a minute, I'm describing myself. But anyway, there's always somebody that says, I've been through managed care in the 1990s, and that didn't work. And so how do we know that this is going to stay put? Well, I think there are some key differences here this time. One, it's not the insurance companies that's monetizing value necessarily. Increasingly, providers, hospitals, doctors, even advanced practice nurses and physician assistants are starting to monetize the value. Even though our information systems drive us all to distraction, they are getting better, and they're better at managing cost and quality. And from my perspective, of course, we're getting closer, not close necessarily, but closer to agreement around what quality of care actually looks like. So accountable care, kind of termed by, at least by CMS, as alternative payment models, pay for value or value-based payment. So that's why the preface with value-based care is important, not just because that's what we want for our own families and our own neighbors, but it's also the way we're going to be paid and remain viable in perpetuity is by getting paid for value-based care. So that's value-based payment. These are new, and that's in contrast to fee-for-service and cost-based reimbursement, which pay for volume. They pay for volume. Even though it's easy to think that cost-based reimbursement is a zero-sum game, that's not quite true. If we increase our volumes, we actually increase our profitability under cost-based reimbursement. So this idea of accountable care, value-based payment, is really rapidly expanding. In this particular slide, I use the numbers 700 plus, 20 plus, 400 plus, mainly because the numbers are changing pretty rapidly to the point it's hard to keep up. But this idea of accountable care organizations, which are delivering obviously accountable care, are rapidly expanding. And this really only got started in the latter part of 2012. So to think what's happened in just a short 3 years is really astounding. And if you think it's only happening kind of in Medicare, not true, not true. We don't have 2015 data yet, but from 2013 to 2014, we went from 11% of commercial, this is in-network payments, linked in some way to value, to 40%. And a commitment by a consortium of healthcare payers, consumers, and providers has said we want that to be 75% by 2020. So I'm convinced that this idea of value-based payment has legs, and it may not be ACOs. In fact, I think most of us believe that accountable care organizations are simply the launching platform for new ways to reward value rather than simply rewarding volume. It's pointing the way to replace fee-for-service. So value-based payment has legs, maybe not accountable care organizations, but this idea of accountable care with a small a, small c certainly does. And in fact, as some of you may be reading about, we're now increasingly talking about accountable care communities. So how is it that healthcare providers and human services providers can come together for the health of a community, not simply a group of patients? Devilishly difficult, really exciting, really exciting. Here's the goals from CMS. These alternative payment models, which include shared savings programs, that's ACOs, patient-centered medical homes, and bundled payments. So those are the three categories that CMS talks about when they talk about alternative payment models. And you can see in the column chart there that the aggressive CMS goals from Secretary Burwell announced about 1 year ago, showing that she wants 50% of all Medicare payment by the end of 2018 to flow through APMs. And then the remaining fee-for-service Medicare payment linked to quality and value in some way, 90%. So this is pretty aggressive. And when this first came out, I think a lot of us said, yeah, we knew this was coming. We just didn't realize how quickly her goals would be set or how aggressive they would be. And for better or for worse, this aggressive timeline favors those organizations, healthcare organizations, who already have experience managing financial risk, who already have experience managing the health of populations, and also, by the way, have deep pockets to weather this transition. Now, all is not doom and gloom. And in fact, the rapid expansion of ACOs in rural areas tells us that rural, at least in large, believes that it can compete in this new world. And I think it can, and I certainly hope that it can. In fact, that's the intent of the work that I'm spending a lot of my time on, is how can we ensure that rural competes successfully around quality, better care, around improving the health of our communities, and spending our precious resources more wisely. Now, there is this 10% right here. I don't know if you can see my pointer or not, but I'm pointing to the top of the 90%, the 90%, top of that, so the remaining 10%. So if 50% of Medicare payment is going to flow through alternative payment models, and then 90% of the remaining fee-for-service is going to be linked to value in some way, what about the remaining 10% that's not paid based on value? So I wrote here, can rural critical access hospitals remain under the radar of value-based payment? Could they kind of sneak under? And would that be a good thing? Well, I'm going to argue no. I'm going to argue no. We have experience in this country and in the world that separate is rarely equal. And I worry that if we accept to be the outliers, the outsiders, receiving fee-for-service exclusively, unfettered by quality requirements, unfettered by efficiency requirements, incapable of doing the data analysis and the improvement in efficiency strategies to compete in the rest of the world, I believe that we will fall behind. We will not get innovation grants and the support for the big systems that can do this already. And maybe one of the most important ones is it has become increasingly clear that critical access hospitals, rural hospitals, and physicians really need to be, using the words of Stephen Covey, interdependent. And we have long worried about physicians who choose to form accountable care organizations or other type arrangements at the exclusion of hospitals. And in fact, that's happening quite frequently. And even something different than that I kind of predicted but didn't have a good example of happened just recently. A consortium of 7 critical access hospitals in a Midwestern state planned to be bold, develop their own ACO, and during the process of trying to develop that ACO, one of the large primary care groups left that consortium associated with a distant ACO and took their patients with them. That new planned consortium of 7 critical access hospitals no longer had the Medicare beneficiaries numbers to be able to develop an ACO as the physicians who left. So taking patients with them, changing hospital referral patterns, changing specialist referral patterns based on value, based on quality and patient experience and efficiency will indeed start to happen, and it will happen in rural as well. And what I worry is that we'll be left with a 2-tiered health system, urban and rural, value-based and volume-based. And as I said here, separate is rarely equitable. And I don't think we'll be able to compete effectively in a 2-tiered health system. So my plea is to think about the future in a way that we too participate in this volume to value transition. We don't simply put our heads in the sand and hope that it passes us by. We don't become immobile staring at our navels. Instead, we innovate in a thoughtful and experimental way. So, but let's just assume for a second that we are one of those navel gazers. And what we really want to understand is, so what's it going to look like financially for my critical access hospital as I move forward in fee-for-service? So that was the question that we put to Eric Schell and our other kind of financial consultants at Rural Health Value, Jane Jerzak from Whitley and Roger Thompson from Seam Johnson. And we said, let's develop a tool that assesses what revenue and operating revenue and reserves look like for a critical access hospital 5 or 6 years down the road if they're strictly relying on fee-for-service and cost-based reimbursement. And what we wanted to do is we wanted to allow the hospital CEO and CFO to actually design the assumptions that go into this model. But here's some assumptions that I think are probably reasonable. And you all can comment about these if you think they are or they are not. And I think we're going to see increasing competition based on cost, quality, and service. And I just gave an example where that happened. Does anyone think that the labor, supplies, meds, and technology costs are going to go down? I don't think so. I think those are going to go up at least in the inflation rate, and certainly if history is any guide, meds and technology costs are way above regular inflation rates. Commercial payers are increasingly reluctant to fund the difference between cost-based reimbursed Medicaid and Medicare and what they're paying. So I think we're going to find increasingly aggressive contracting with commercial payers. And some of you may already be seeing that already. I mentioned that example that I just heard about 3 or 4 days ago, increasing physician pressure to align with successful healthcare organizations. You know, no matter what you think of physicians, they're generally a pretty smart bunch, a pretty perceptive bunch, and they want to be aligned with winners. So one of our roles as rural healthcare organizations is to prove to our physician colleagues that we will be winners. We will be winners in the future. And if we lose those physicians, and we'll lose at least some of that physician-driven ancillary service revenue, which in many critical access hospitals is the difference between profitability and loss. So I think those are probably reasonable assumptions that will impact profitability, but you can comment about that, and you may have a different view, and that's perfectly okay. So we ask here, can we project our financial future if you, not an outsider, if you help write the assumptions? So that's what we did. Now this is, again, not for anybody to kind of write down. This is simply kind of one of the screenshots that talks about the assumptions that go into this particular Excel-based pro forma or financial model. So it asks really some information that most of you who are CEOs or CFOs should generally have readily at hand. But we've listed here where these data come from: financial statements, PSNR, the worksheets which are in your cost reports, and then a forecast. So how you forecast how things are going to be changing, how price is going to change, how your utilization is going to change, et cetera, et cetera. So the key here is that you are providing the assumptions for the model, because recall that any model is only as accurate as its assumptions. So we ask that you write the assumptions, and then the model will return projections for profitability and reserves going 5 years out. Again, based on fee-for-service, cost-based revenue exclusively. No value-based payment contracts, no ACOs, no bundled payments, no patient-centered medical home bonuses, etc. And this is what it returns. It return charts that look something like this. Now, this is a relatively positive one for this particular hospital, but nonetheless, the idea is that you get a sense for your strategic planning and for your board about how you should make investments going into the future. And if the idea is that I think I can survive in the current fee-for-service cost-based reimbursement environment, financially, now we're making financial decisions now, then I don't see a burning platform to change. I do see a burning platform for things like participating, engaging your physicians, for example, getting ready for value-based care. But I don't see a burning platform for you to kind of suddenly bet the farm on doing something different than fee-for-service and cost-based reimbursement. But we know hospitals are closing right now. Now, the rationale for the closures are multiple. Some are simply due to the economic environment in which the hospital resides, and nobody immediately within the healthcare system is in the capacity to fix that right now. But some are lack of alignment with physicians, for example. Some may be, heaven forbid, poor management decisions. But we think that this particular tool gives you one additional bit of information as you make your strategic planning. So I encourage you, go to ruralhealthvalue.org, click on Tools and Resources, then click on Financial Risk Management, and then click on CH Financial Pro Forma. It's pretty self-explanatory. It has a set of spreadsheets set up so it has instructions, data entry sheet, and then kind of output sheet that look a bit like these graphs, these charts. So you can see that, and I think it's worthwhile as you think about your financial strategic planning. We really hope that it's helpful to you. So I wrote in the second bullet that we predict that many CHs indeed can survive for now under fee-for-service and cost-based reimbursement. That not everyone is in dire straits, but the sub-bullet though is that some will fail and close. So I think it's helpful as you think about strategic financial planning to have these kind of data available to you as you start to make decisions in how you invest and how you decide about where operational changes are going to happen in your hospital. So I think there is a way forward here. I do. Remember I said in one of those slides that I think rural can compete in this new world. And here's what I think the way forward is one, use as sophisticated financial modeling as we can to drive strategy. With all financial modeling, the output is dependent upon the inputs. So those are the assumptions. So we ask you to make those assumptions and then see how the output is and test the model. But this is how you make informed financial strategic decisions rather than management by guess and by golly. Next, since we are primarily in a fee-for-service and cost-based reimbursement world, do those really, really well. Now, I'm not the expert here, but understand your revenue cycle. Understand the importance of proper contracting. Understand the importance of your purchasing policies. Understand how you can drive appropriate volume into your hospital, appropriate volume. So do that really, really well. And remember that no matter what payment system you're operating within, whether that be fee-for-service, pure fee-for-service, cost-based reimbursement, alternative payment models, always efforts around increasing efficiency in your organization, such as Lean or Six Sigma. Six Sigma is primarily about reducing variation, but Lean is reducing waste, will always be beneficial to your bottom line. So first, second, do fee-for-service and cost-based reimbursement really well. And then as you think about your investments in value-based care, make them informed. This does not need to be by guess and by golly. We need to find the appropriate middle ground between navel-gazing, that's one extreme we don't want to do, and the other extreme is innovating yourself right through your reserves. We can't be thoughtless about how we invest in value-based care. So we talk about ACO training wheels, and here's some of the training wheels. Well, I've already mentioned primary care affiliations. Increasingly, primary care providers will be the ones directing care, and eventually the dollars will flow through their patients. That's how ACOs work. ACO beneficiaries are attributed to the ACO through a primary care provider. We need good data access and analytics. We are hamstrung without good data. We really need to pursue getting good data to make wise financial and strategic decisions. And interestingly, and as an aside, one of the ways that you get access to Medicare data is through participation in ACO. It's close to being criminal that we don't have that even without participating in ACO, but one of the beauties of participating in the Medicare ACO is you have access to data. We can develop a value-based referral network. Let's use those referral hospitals that provide our patients the best quality, the best patient care experience, and the least cost. Same way with our specialists. Same way with distant services as well. And begin kind of thinking about care coordination. Now, I wrote limited here because I know it sounds a little odd, especially as a physician, but you can't invest too much in something that's going to hurt you financially. I got a good example. Worked with a hospital, and the story went that the CEO participated in an emergency department superutilizers reduction program. Great idea. Good for patients. And he lost $250,000 in revenue from his ED. He had to close that program down. And I understand why. You can't afford to do good deeds that kill your bottom line. But if we have a little bit of largesse, if we do have some wiggle room, then let's invest in things that make sense for our community and move us toward that delivery of value-based care. I'll wrap up here with kind of a last quick description of the Rural Health Value Project. Here's our website. Tools and resources we have available. We have profiles and innovation. We have white papers and articles and presentations. And then you just heard about one of our new tools, the Prioritization Hospital Fee-for-Service and Cost-Based Reimbursement Financial Pro Forma. Somewhat similar to that, we will hopefully have available to you in the spring of this year a shared savings contract pro forma. So this is how do we evaluate an ACO contract from a payer or from a health system, or we're trying to design it ourselves. How would we do that? It's more complex than thinking about fee-for-service and cost-based reimbursement, so it's going to be a more complex model, but we are developing that along with a again, those financial consultants that I mentioned, but also Premier Inc. is kind of our main contractor with that, and more to come as well. So that wraps it up. We talked about how to prioritize our value-based care capacities and have them ready for action planning, and we talked about the importance of strategic financial planning, especially around cost-based reimbursement and fee-for-service, and how we need to understand how our finances will look in the future as we make decisions about value-based care investments. Thank you very much. I'd be happy to take a listen for questions.
Thank you, Clint. Great. There were a few questions that came in during your second half. Oliver Crane is wondering, how will value-based payments affect the amount of administrative work in getting reimbursement?
Oh, I don't know the answer to that yet. I would make an assumption that, well, let me back up a little bit. From an administrative standpoint for billing, there's no difference, at least in the Medicare ACOs, and that's what I know the best. In Medicare ACOs, physicians and critical access hospitals and other providers bill exactly as they always would do. Always. There's no difference, no difference. The only difference is that CMS does a reconciliation at the end of the year and compares how much you and others have charged them for their beneficiaries and compared to what they think you should have charged them. And if there's a difference, you're able to share, Medicare shares those savings with you. If there's a difference and and it's less for Medicare, spend less. So the administrative burden for billing is no different. Now, what I mentioned before is that you also now get claims data, and you probably do need a system that adjusts those claims data in ways that are actually readable. And maybe some of you have seen claims data files, and they're just mind-numbing. But nonetheless, if we have a data analytics package that is able to translate Medicare claims data into something usable for us that we can understand where our patients are going, that's really important stuff. I haven't talked to Toby Fryer about this specifically, but Toby is a CH administrator in New Ulm, Minnesota. So he was looking at his ACO data and found out that his greatest single expense for this particular period was a swing bed stay at a competing hospital. So he found out that, hey, he asked strategically and also operationally, why aren't we tracking where our patients go and where they leave and where they get their skilled care? So that's a good example of maybe there's some extra burden of reviewing these data, but it provided some great insights.
Thanks, Clint.
Uh-huh.
Tom Nordwick was wondering, how is the value-based purchasing going to be implemented with the CA reimbursement system, which is currently cost-based payments? Has a path been identified? I know you touched a bit on that, but if you wanted to add anything more on that?
Yeah, I can. So Tom, bear with me. I'm trying to find a CMS contact who is kind of in charge of this particular question. How do we attribute CAH costs to an ACO? So bear with me a little bit. I'm going to tell you what I think I know is correct. And if you guys or if someone else has information that differs, please tell me, because all of us in my group are struggling with this. This is kind of what happens. You have a per diem. As a CH, you have a per diem for which you send a bill. No, I'm going to start with inpatient. You have a per diem rate that's kind of dependent on your last year's cost report for an inpatient day. So when the ACO is calculating the cost of an inpatient care, it simply multiplies the number of days, inpatient days, that your particular ACO beneficiaries have had in your hospital, and then multiplies that those days by your per diem rate. For services that are not inpatient, I understand that hospitals have a kind of a global cost to charge ratio, and then what happens then is, so you bill Medicare for an MRI. We know from last year what your cost to charge ratio was, and then that's applied to that particular charge, and the and then that becomes kind of the cost to the ACO based on cost to charge ratios. Now, cost to charge ratios differ throughout the hospital, so why they're using just one single cost to charge ratio, I'm not sure. And that seems kind of like a very blunt instrument to me, but nonetheless, you know, I'm not people working at CMS. So it's using your current per diem multiplied by the number of days, inpatient days that your ACO beneficiaries have in your hospital, and then the same for the services that the beneficiary receives, times the charge times the cost charge to cost ratio. Does that come close to answering your question, Tom?
And Tom, you wondered about the transcript available later. The webinar slides will be available as well as this webinar recording on our playbacks page.
Let me please add to that last question, if I could, Kim. That's a real, it's a good question, and for this kind of non-financial guy, really tough. But I've asked a lot of people about this. I've asked people at FRHP, I've talked to Eric Schell, I've talked to Lynn Barr, and I think we're honing in on the right answer, and it shouldn't be hard. This should not be a hard question to answer, but it sure seems to be. So if any of you have better resources for me, please send them to me. We're really wrestling with it.
Well, Tom said, sounds like a clear path is unknown.
Well, a clear, maybe it's not clear to me. I think there is, I mean, obviously there is a way that's being done. Oh, it's another thought, just so you know, which I disagree with. What CMS does is they remove IME and DISH payments from the cost at PPS hospitals. So even the ACO doesn't see the true cost at PPS hospitals because those two things are removed. So it's, I think there's a path. We can argue about its clarity. And also, because it's not at least 100% clear to me, it's hard for me to judge whether it's fair. And that's even more important question.
It looks like Oliver Crane has another question, but maybe I can just ask one while he's typing. Clint, okay. How do we know if the fee-for-service cost-based reimbursement pro forma accurately predicts the future?
Well, you know, that, of course, that's a really good question, Kim, because that's the #1 question of any kind of pro forma. And for those of you who kind of suffered through this in graduate school, probably if you ask the professor, you know, how do I know this is valid and accurate? What the professor probably should say is that the validity, thus the accuracy of returning the values that you're looking for, are dependent upon the assumptions. So that's why we were very specific in this tool to ask you to define the assumptions. You define where inpatient volumes are going. You define where your commercial rates are going. You define where your staff compensation costs are going, your information technology costs are going. You make those assumptions, and then the model will return kind of a future financial performance based on your assumptions. So we think that if you do not have a good handle on historic trends and how they're likely to change over the next 5 years, then no model is going to help. On the other hand, if you're really thoughtful about financial planning and you watch trends, and I bet most of you do, you watch trends and then start thinking about in an informed and rational way based on what's happening in the world, what your colleagues are saying, and what your trends at your own organization are, you'll be able to make some pretty accurate assumptions about how trends over the next 5 years, and I think that'll be helpful to you.
Great, thank you so much, Clint. Oliver's question is, I'm concerned about with increasing complexity comes increasing resources. My critical access hospital is already pretty strapped for people and resources. Do you see the reality of limited resources at critical access hospitals affecting how alternative models are structured for critical access hospitals?
Oh, oh boy. So there's multiple parts to that question. Let me see if I can do this. First, let me talk about the program. Again, I'm most familiar with the Medicare Shared Savings Program. Let me talk about the program, and then let me talk about the realities in critical access hospitals. First, about the program. It's really surprising. If you watch the regs, the Federal Register, and the requests for information, requests for comment from CMS, the regs around ACOs are changing almost every quarter. They're just changing all the time. And they're changing in general to make it more attractive to providers to participate, more attractive. So, for example, we've complained about using historic costs, our own historic costs for us to benchmark against. If you're already a low cost provider, we're competing against ourselves. CMS is changing that. CMS is changing it. So every time I turn around, CMS is trying to make this program more attractive without breaking the bank, without kind of charging taxpayers more. So I can't predict yet exactly how much more attractive the ACO program will be, but I think we'll find is they want people involved in it, but at the same time they're trying to balance the tension of not charging the taxpayers more. So this will never be a free lunch. The House always wins, but can we lose less by participation in these programs? And I think the answer probably is yes. So from a program standpoint, this is constantly evolving, generally in a positive way. Now internal, boy, you said it so well. With increased complexity comes increased resource need. And that's exactly true. That's why I wanted to comment about the billing part of ACOs. There's no difference in your billing. So with that increased complexity, there's no increase in the billing. There's increase in trying to account for revenue, potential shared savings revenue that's not yet arrived. There's no good way in GAAP to be able to account for that. You have to account for it in your budgeting. So how do we offset investments in care management, for example? How do we offset the cost of a care coordinator? And there isn't a good way, as I understand it, in GAAP to be able to do that other than just through budgeting. So in any event, that starts to add complexity. And I think it will increasingly take sharp CFOs to be able to understand how much investment can we make in value-based care without jeopardizing the current fiscal success of the organization. And all organizations do R&D, but the problem is that we in rural hospitals with 1, 2, 3% operating margin don't have as much wiggle room for R&D. So that's why CMS has responded with the AIM program, for example, the primary care transformation work. All of this are grants to actually allow us a bit of experimental room. Now again, there's no free lunch, but I think the government's making a reasonable effort to include less resourced organizations in alternative payment models. But yep, you're right. Increasing complexity generally means increased resource utilization. Very, very good point. What else is new? I mean, geez, implementing an EHR is the same way. Negotiating one more contract is the same way. So I think we're probably pretty used to it, but when do you cry uncle and decide that I'm going to quit and open a bait shop? I don't know. My hope is that people on this call get enthusiastic about the future, understand that we do have a path forward, but it's not all doom and gloom, and that we should, for the sake of our communities, the sake of our staff, should be participating in this transition.
Great. Thank you so much, Clint. Great questions today and great answers as well. The recording of this webinar series along with the slides will be available on our Help